please put your questions in the Q&A box and not in the chat box, because it's difficult to look at both the boxes. So if you have anything else, put it in the chat box, but all the academic questions for the speaker, Dr. Sonal, please put it in the Q&A box. Dr. Sonal, over to you.
Thank you, Dr. Mala. And we start from where we had left. It was estrogen. So we were on the baseline scan still, and going to, after completing androgen, AMH, FSH, LH, we are now moving to estrogen. The granulosa cells of the big antral follicles and the larger follicles stimulated by FSH, they are the ones which produce estrogen. Perifollicular vascularity of the dominant follicle starts developing as early as 8th day of the cycle. You remember I said that you can see that those vessels so clearly heading towards the dominant follicle. You can see in this picture. And this is an indication of its development of FSH receptors. And this is its indication of starting to secrete estrogen. Vascularity indicates a dominant follicle. It represents FSH receptor development and rising levels of estrogen. Now, this happens after the baseline scan, before the actual pre-ovulatory scan. So the vascularity of the follicle keeps on increasing as the estrogen levels are rising. Now, what are the things that are important to us when it is about the pre-ovulatory phase? 1, estradiol, to know the follicle is mature or not. 2, LH, to know the surge has started. And if it is started, is it on time or it's untimely? And the third is progesterone. We need to exclude its premature rise. So how does that happen? How do we know about that? The pre-ovulatory follicle, as we know, a dominant follicle which is growing at a rate of 2 to 3 millimeters a day, it's called pre-ovulatory beyond the size of usually 18, normally in a non-stimulated cycle. In gonadotrophin cycle, the pre-ovulatory phase may arrive as early as about 16-17 millimeters, and it may sometimes be delayed up to the size of 24 millimeters also. So that is the size of the follicle, and a sonolucent halo appears about 24 hours before the ovulation. A tiny solid projection cumulus also appears almost about the same time, 24 to 36 hours before ovulation. And it's about 6 to 10 hours before the ovulation that a low-level echos start showing up parallel to the follicular wall inside the follicular lumen. And this is because of the separation of the innermost layer under which the ovum is secured. So it's a process which is preceding the ovulation actually. The cumulus that I showed you in the previous image, this cumulus, of course, it's a very tiny solid structure and can often be missed on a 2D ultrasound if the proper optimization of the image is not done or the probe is not scrolled across. 3D, though, is a better or a more easier modality to show the cumulus, because at a time it shows the entire lumen, it shows all the walls, and the cumulus can be well appreciated on 3D. So if I'm doing 2D, I will be able to appreciate cumulus in about 30 to 40% of mature follicles, but if I'm doing a 3D, I can appreciate it in at least about 85 to 90% of the mature follicles. Fall in the perifollicular RI starts 2 days before, 48 hours before the ovulation, and reaches the lowest at ovulation. This perfectly correlates with the sharp rise in estrogen, and as you can see here, 48 hours before the ovulation, the steep rise in the estrogen starts, and that's where the RI of the follicle falls. That means the RI of the follicle in the pre-ovulatory phase can be correlated to the estradiol levels and therefore to the follicular quality. But when the surge starts, when the estrogen level rises beyond this start of the estrogen surge, so somewhere midway, that's when the LH surge starts. That's when the PSV also reaches 10. So the first, as the estrogen starts rising up, that's where the RI falls, and then as the estrogen level further rises, and there's a time to for the surge to start, that's when the PSV also reaches 10 centimeters per second. If the follicle is a good quality, that's when these blood flows, they cover at least about 2/3, preferably 3/4 of the circumference of the follicle, and only those vessels which overlap on the follicular wall are the perifollicular vessels. So we are talking only about those vessels. This means that these flows can be correlated with the high estradiol levels and therefore with the ovum quality. The ovarian flow correlates well also with the oocyte recovery rates and hence may be useful in determining the most appropriate time to administer trigger to optimize the oocyte recovery rates. And more uniform the blood flow is, more uniform the vascular network is surrounding the follicle, better is the chance to produce pregnancy naturally, because if the blood flow is better, the estrogen level is better. Estrogen level is better, that means an individual follicle is producing sufficient estrogen, and if that is the case, that is when the follicle in the ovum inside is a better quality. The blood flows which you are seeing here as a 3D power Doppler can be calculated by doing the vocal. So after acquiring the 3D volume of the follicle, you do a vocal, find out the follicular volume, then you select an outside shell of 2 millimeters, and after that, when you render that image, that's when you would see the perifollicular flow, and that is that can be quantitatively assessed as VI-FI and the VFI parameters, which tells you about the abundance of the flow, average intensity of the flow, and the perfusion of the follicle. In a study of more than about 1,000 patients done long back, published in 2009, we found that in spite of the follicle being at least about 17 to 18 millimeters, the vascularity covering at least about 2/3, preferably 3/4 of the circumference, with RI of less than 0.5 and a PSV of more than 10, the pregnancy rates were better only when, before the trigger, we had follicular VI values between 6 and 20, and the FI values of more than 35 gave us very high pregnancy rates, as you can see here by the pink portions of those columns. These are of more importance in poor responders and in those cases where there are multiple unexplained failures. That means doing 3D power Doppler explores more reasons why the patient has not conceived and therefore explains the cause of infertility rather than calling them unexplained infertility. The receptor organ to this estrogen, which is produced by the follicle, is of course the endometrium. And that receptivity is seen in the form of endometrial growth, endometrial morphology. You all know the multilayered morphology of the endometrium, and of course the endometrial vascularity. Apart from that, it is also the cervical mucus, which represents the estrogen effect of estrogen on the estrogen receptors. The presence of estrogen, therefore, is perceived as increase in the endometrial thickness, better endometrial morphology, endometrial vascularity, and the cervical mucus. If I say so, the estrogen actually starts rising as early as the dominant follicle. We know the blood flow started there. So at that time, the endometrium starts becoming multilayered. It is still thin, about 6 millimeters. It becomes multilayered as early as about 7 days before ovulation. With the rising estrogen, it increases in thickness and it grows to a typical grade B morphology, wherein you have a multilayered endometrium with hypoechoic areas in between. And this morphology is achieved when there is the estrogen level is almost equal to like one mature follicle, about say 100 to 200 100 to 300 picogram per ml. I know the normal level is about 150 to 200 picogram per ml per follicle, but up to 300 picogram you will still get a grade B endometrium. When there are either multiple follicles or the cumulative estrogen is high, as in PCO patients, that's when you get grade A endometrium. So if it's not a PCO patient, you usually expect a grade A endometrium when there are 3-4 mature follicles, as it occurs in ovulation induction cycles with gonadotrophins. So it's a multilayered endometrium with echogenicities in between, which is a grade A endometrium. And then when they're truly hyperestrogenic states like multiple follicles, PCO patients, that's when you get a grade C endometrium, which is an isoechoic endometrium. It's not hyperechoic. It is homogeneous isoechoic endometrium. It has an echogenicity same as that of the myometrium, and that is hyperestrogenic endometrium. And all three endometrial morphologies are good for implantation provided the vascularity is good. At the same time, when the follicular vascularity starts, we know because estrogen is representing also as estrogen, so the vascularity of the endometrium also starts developing almost the same time. And the endometrial and the subendometrial flow increases in the follicular phase and reaches maximum 3 days prior to ovulation in a non-stimulated cycle. But in a stimulated cycle, it almost correlates with that of the follicular maturity. So when the follicular RI falls, that's when the endometrial vascularity also reaches almost maximum. These blood vessels must also have low resistance flow because the estrogen, because continuous oxygen supply to the endometrium is required before the ovulation, before the implantation occurs, and it should cover at least 5 millimeter square area because that's the minimum area required for the embryo to come and implant. So endometrium, which is either grade A, B, or C, has vascularity reaching the inner layers of the endometrium, which is according to the Applebaum classification called zone 3. And for vascularity, should have an RI of less than 0.5 and should cover at least 5 millimeter square area. 3D ultrasound talks to us about volumes rather than thickness of the 3D power Doppler, and 3D power Doppler gives idea about the global vascularity. Now, why is this volume required? We know that many times we get 7, 8, 9 millimeter endometrium, but the implantation doesn't occur and we don't understand the reason. Of course, one strong reason is the vascularity, but the second strong reason is volume. When the uterus is short, in spite of 8 millimeters thickness of the endometrium, the volume may be lower, lesser than 2 cc. There are 3 different studies, which one says minimum volume of 2 cc, one says minimum volume of 2.63 cc, and the third study of 3 cc. So 2 to 3 cc is the minimum volume required. If that volume is not achieved, no matter what is the thickness, no matter what is the vascularity, the implantation is very less likely. So that's why 3D is important to us. 3D is especially important, the volume is especially important in cases where the endometrium is persistently thin, the uterus is very long, or the endometrium is thick but the uterus is short. Apart from the endometrial volume, which was 3 cc in our study, minimum 3 cc in our study, it was endometrial FI at least 20, endometrial VFI at least 5, which were essential, which were considered to be essential according to the same study of ours, which I described for the follicle. You remember we talked about the follicle and the 3D power Doppler values. So the same study, we also evaluated the endometrium, and according to that study, Apart from the endometrial volume of 3 cc, we required endometrial FI of at least 20 and endometrial BFI of at least 5 for better pregnancy rates, apart from the 2D and the color Doppler parameters that we just described. And there is a sufficient literature proof to that too. No pregnancy was achieved when the endometrial volume was less than 3 cc and the BI was less than 10. And exceptionally better pregnancy rates were achieved when the volume was more than 7 and the endometrial BI was between 10 and 35. Lower RI between 0.5 and 0.57 and higher FI between 11 and 15.4 gave better pregnancy rates according to another study. And therefore, it is proved that better endometrial vascularity, which represents better development of estrogen receptors, and that indicates better vascularity. That indicates better receptivity. So, better vascularity means better estrogen receptor development, means better receptivity to the embryo. Apart from that, it's also essential to look at the uterine artery Doppler. We discussed in the beginning that whenever the androgen is high, the uterine artery resistance is higher. It's not higher only in the early proliferative phase, because we know the androgen doesn't change significantly throughout the cycle, and therefore the uterine artery resistance also keeps itself high throughout the cycle. So normally the uterine artery resistance at this stage, the PI should be less than 3.2, but in PCO patients it is higher. That is higher. There's lower diastolic flow. So discontinuous or non-consistent flow of oxygen to the endometrium, and therefore less development of inconsistent flow to the endometrium, no flow or less flow in the diastole, and therefore less development of the estrogen receptors, and therefore poor endometrial receptivity. Where hormonal assessment therefore tells us only about the immunoactivity or levels of the hormones, ultrasound tells us about the bioactivity, by the effect seen on the change in the morphology and in the vascularity, and also about the receptor development. And that is very important to us, because it's the bioactivity that matters for fertility. It's not the immunoactivity. Now, that's about up to the surge. Now, what happens after the surge? After the surge, if you remember the first picture that I showed you about the hormonal changes, after the surge, the LH falls, the estrogen also falls. The progesterone takes a few days, 3, 4, 5 days to rise to a plateau. And therefore, with the rise of the LH surge, I also told you there is a rise in the PSV of the follicles. So there is an estrogen rise, there is a fall in the RI. After that, the PSV starts rising. PSV further keeps on rising with the LH surge. Therefore, and there is a marked increase in the peak systolic velocity around the follicle in the presence of relatively constant PI, could be a sign of follicular maturity. And vascular changes at the time of impending ovulation include increased vascularity of the inner wall of the follicle and a coincident surge in the blood velocity just before the eruption. So this is what happens at the surge. So here the estrogen level starts rising and the RI falls. After that, as the estrogen rises, the RI is still falling, and then with the rise in LH, the PSV of the follicle rises. That means if I have a low RI, as it's mentioned here, if I have a low RI and the PSV is not 10, which is at the start of the surge, it's higher, 20, 25, 30. That means I'm not here on the surge, I'm somewhere here on the surge. And if I'm somewhere here on the surge, that means I'm not 36 to 42 hours away from the ovulation, I'm closer to it. And therefore, in these patients, if I'm going to plan an IUI, I must do an earlier IUI, because the ovulation is going to occur earlier. It is about 29 hours before the ovulation that the PSV suddenly starts rising, as we have just described. That means that if the PSV is high, you need an earlier IUI. Now, this was a study which was done long back, presented in one of the ISWA conferences, and it said that if the PSV of the follicle was high on the pre-ovulatory scan, a double IUI, the first IUI at 12 to 14 hours after the trigger, and the second IUI after 36 to 38 hours must be done. If you see here, for all the follicles where the PSV was more than 15 were taken into study, the single IUI 36 to 38 hours, double IUI 12 to 14 and 36 to 38 hours were done randomly in this patient. So alternate all the odds single IUI or the evens double IUIs. And what we observed was that in all the patients who had a PSV of more than 20, no matter what was the stimulation protocol, the PSV was more than 20, double IUI pregnancy rates, which are indicated by yellow bars, are much taller than the red bars, which indicate single IUI pregnancy rate. That means when the PSV was more than 20, it was the earlier IUI which gave us results, and therefore we suggested that all the patients who have a PSV of more than 20 must undergo two IUIs 12 to 14 and 36 to 38 hours. But a further study was taken up where we divided these into further smaller segments, and we have now come to a conclusion that if the PSV was between 10 to 15, we would do only one IUI. If it was between 15 to 20, 5, we would do two IUIs 12 to 14 and 36 to 38. And if it was more than 25, we would do single IUI 12 to 14. But you can still omit this double IUI into a single IUI 24 hours if you can plan the timings like that. So depending on the PSV, should we decide how many IUIs or when should the IUI be done. And that is a very important message that we get from ultrasound that you will not get from your hormonal assays. Now, this is what happens into the follicle, rise in the PSV after falling of artery. What happens to the uterine artery? Because of the fall in the estrogen level and the progesterone, which is also low, these are the only two factors which lead to increased vascularity or low resistance vascularity to the endometrium. Both these levels are low, so the endometrial vascularity decreases. And along with that, because of low estrogen and progesterone, in that phase, even the uterine artery resistance increases. So, here again, a very important message. If I'm doing a pre-ovulatory scan and the uterine artery resistance is high, along with that, if the follicular PSV is also high, that means I'm close to the surge, and that means I must do an earlier IUI or a double IUI. But if I get low follicular PSV, that means the follicle is still not mature and I must continue stimulation till I get proper parameters. Remember, Doppler is not to cancel the cycle, it's to time the cycle properly. Now, this is the effect of the surge on the vascularity. Is there any effect on the morphology? Of course, yes. As the surge starts, you know that with the start of the surge, there is also a rise in progesterone levels. And this progesterone levels has to show its effect on the endometrium, because endometrium, apart from the estrogen receptors, also has progesterone receptors. And that progesterone receptors, they show the effect of progesterone in the early phase as fluffiness of the outer margin of the endometrium. Remember that fluffiness of the outer margin of the endometrium tells you that the progesterone levels have started rising, but are still within physiological limits, both time-wise as well as the extent-wise. So as long as the endometrium is fluffy with high uterine artery resistance, with high PSV of the follicle, it means that the surge has started. It is a assuring sign that surge has started and you should do an earlier IUI. On the other hand, if you see that the follicle is already ruptured, but the endometrium is still fluffy, which means it's a fresh rupture and you can do an immediate IUI. In cases of your IVF, it means that the agonist is not working well, otherwise the LH would not start and the fluffiness of the endometrium would not occur because the progesterone would not rise. If you see that the endometrium has started becoming fluffy before your trigger in down-regulated cycle, it indicates a possibility of a rise in progesterone But if the outer margin of the endometrium started becoming hyperechoic, it is definitely a pathological rise in the progesterone and will affect the endometrial receptivity. So this occurs the first 24 hours after progesterone exposure. So within about 10-12 hours of rupture. This occurs after 24 hours of progesterone exposure, and the levels usually higher than 1.5 nanogram. And as the progesterone keeps on rising with the progressing luteal phase, the outer margin hyperechogenicity progresses towards the center. It's in the mid-luteal phase that the entire endometrium becomes hyperechoic. I have already discussed, I'll just add once again that the progesterone effect on the vascularity, there's highest vascularity in the pre-ovulatory phase. Early progesterone rise just leads to decrease in the vascularity and compactness of the endometrium. And then in the mid-luteal phase, when the progesterone reaches a plateau, that's when the endometrial vascularity again increases to pretty more. Low endometrial, so that means that this is the stage post ovulation. Peri-ovulation and post ovulation is this stage where there's low vascularity and thinned out endometrium. If you say that this is the phase when the embryo is going to come and implant, it is at that time that the vascularity is low. So how the implantation will occur? Very importantly, low endometrial VI and VFI in the pregnant group was found on the day of oocyte retrieval. The day of oocyte retrieval means periovulatory. A non-significant trend of higher implantation and pregnancy rates were found in the patients who showed absence of endometrial flow on the day of oocyte retrieval. And this can be explained because during the transit of the fertilized embryo from the tube to the endometrium, a low oxygen level is required. Therefore, during this period, periovulatory period, the endometrial vascularity is lower. Only after the implantation starts occurring, the level of the progesterone rises and the vascularity to the endometrium rises. It is this endometrial hypoxia which upregulates VEGF, and it is that which helps further vascularity development and implantation. Therefore, if you are doing an IVF, evaluate the endometrium on the day of trigger or on the day of starting progesterone if it's a frozen cycle, and not transfer or cycle. If you do so, you will find a slightly thinner on the day of cycle. Start to thickness. It still shows a multilayer pattern of AP transfer. Here, hypercoic endometrium will show less vascularity in the day transfer. So, now, coming to the mid phase, just now. The clear correlation between the RI that the progesterone production is normal. But that is not enough. It has to show its sufficient effect on the endometrium. That means the endometrium must have sufficient progesterone receptors, and that can be indicated by the endometrial vascularity, which is reaching the inner layers, and that should also have an RI of less than 0.5, round figure. And along with that, it should have a uterine RTPI of less than 2.5. So, if the uterine and the endometrial parameters are normal, it tells me progesterone production is normal and the progesterone receptors are also well developed. Now, that is all about the natural cycle. Now, coming to the critical situations during the treatment cycle, you have an early recruitment of the follicle. We have discussed that it tells us that the FSH is high. It is also associated usually with less number of antral follicles, but if you and therefore short cycles, which we have already discussed. But if it's in the PCO patient, you have seen that in PCO patients, when as the PCO patients they age, they get older. That's when their longer cycles start becoming normal cycles. Does that mean that PCO is resolving? No, that PCO is not resolving. It's actually the FSH which is rising, which leads to early recruitment of the follicle. and that is why the cycles become normal. So in the PCOS patients also, you may have early recruitment of the follicle, you may have normal length cycles, and that indicates rising FSH. In these patients, the multifollicular, the multiple follicles of PCO, they reduce, but they still remain within the normal range, so up to from 5 to 10 or so. It's correction of the LH FSH ratio because of rise in FSH, which leads to normal ovulation in these cases. If you are doing a baseline scan and you find that the endometrium is thicker than 5 millimeters, it may be either high estrogen or high progesterone, provided the endomyojunction is normal. If the endomyojunction is normal, the endometrium is thickened on the baseline scan, look at the pattern. If it's multilayered, think of either early recruitment of the follicle or PCO, and you'll find the evidence in the ovary on the scan. If it is hyperechoic, that is when it may be high progesterone, and in these cases you will find a residual active corpus luteum. That means you find a residual corpus luteum in the ovary, and if you put on the flows, it will still show low resistance flow, which tells you it is a residual active corpus luteum. Sometimes it does happen that the endometrium is thin, but the corpus luteum is still there and it still shows flows. Remember, it is a regressing corpus luteum, and within 2-3 days, if it's an IUI cycle, you can wait where you're going to start stimulation on day 5. By then, the corpus luteal flow will start decreasing in abundance and increasing resistance. So, making it very simple, if it's a thick endometrium on the baseline scan, look at the junctional zone. If it's irregular, think of acute endometritis. In acute endometritis, you will have thickened endometrium, increased flow, and irregular endomyojunction even in the early follicular phase, where usually the endometrium is thin and non-vascular. If the endometrium-myometrial junction is intact, think of high estrogen or high progesterone. Look for CL if it's high progesterone. Look for either PCO or early follicle recruitment if it is estrogen effect. Thin endometrium in the pre-ovulatory phase. Pre-ovulatory phase, that's when you expect the endometrium to be thicker. Instead of that, if it is thinner, then again look at the junctional zone. If you look at the junctional zone and it is altered, think of adenomyosis, or where the endomyojunction is absolutely not recognizable, a severe adenomyosis, and you may mistake the margins, and therefore you may think it's a thin endometrium. Sometimes it's really thin because adenomyosis may be severe and you may not be able to, and the endometrium may not be able to grow, or it may be chronic endometritis. So it's a thin endometrium, pre-ovulatory phase, irregular endomyojunction. It may be either acute chronic endometritis, or it may be acute, it may be severe adenomyosis. But if the endomyojunction is intact, it's either the follicle which looks larger is not functionally mature, which is the commonest cause. If that is not the cause, then think of Escherman or think of hyperprolactinemia. Pre-ovulatory, thick endometrium, but no follicle seen. It may happen in PCO patients. We are thinking it's pre-ovulatory because it's mid-cycle, it's like 14, 15, 16 days, but the follicles have not matured. It's a cumulative estrogen which is giving rise to a thickened endometrium. Or it may be a freshly ruptured follicle where, as I told you, it may be a fluffy and outer endometrium. Non-rupture of the follicle after the trigger. This is possible if the trigger is given before the follicle is functionally mature. That means you have not seen the blood flows and you have given the trigger. That's when the LH receptors are not sufficiently developed. Therefore, the LH is not sufficiently perceived, and it goes into a luteinized unruptured follicle. Luteinized unruptured follicle is recognized by hyperechogenicity of the outer walls, and also by increasing in the resistance of the perifollicular blood flows. So, if I want to prevent LUF, what should I do? I must be sure that the trigger is given at a correct time, proper size of the follicle, perifollicular vascularity covering at least 2/3, preferably 3/4 of the circumference, RI less than 0.5, and a PSV of more than 10 centimeters per second. Along with that, if it's an IUI cycle or I'm going to plan a fresh IVF cycle, I must also check the endometrium before I give a trigger. It should be multi-layered. It should be at least 6 millimeter, preferably 8 to 10 millimeters. Vascularity must be reaching inner layers of the endometrium. Should have an RI of less than 0.6 and the uterine artery PI should be less than 3.2. So that is what will prevent LUF. The second problem with the luteal phase is the luteal phase defect. And the luteal phase defect may be because of either inadequate progesterone receptors in the endometrium or because of inadequacy of the corpus luteum. We have already discussed a normal luteal phase, and if at all it is inadequacy of the corpus luteum, then you have inadequate corpus luteal flow, because we know that it is the corpus luteal flow which correlates perfectly with the plasma progesterone levels. So if you don't have corpus luteal flow, if you have a very high resistance corpus luteal flow, it tells me it is corpus luteal inadequacy, and that is almost always associated with thin endometrium, hypovascular endometrium, because if the progesterone is not there, not secreted by the corpus luteum, it's not perceived by the endometrium unless it is exogenous progesterone which is supplemented in the treatment cycles. Whereas if it is because of non-responsive endometrium, that is when the corpus luteal flows are normal, but the endometrium is still thin and hypovascular. And it is in the cause that the treatment is also hidden. If it's inadequacy of the corpus luteum, you will need to supplement the corpus luteum with HCG. And if it is because of inadequacy of the corpus progesterone receptor development, that's when you need to develop better receptors, one by drugs like aspirin, and two by providing proper stimulation protocol so that the estrogen priming is sufficient and therefore the progesterone receptor development is on. So the abnormal luteal phase, you want to summarize, it's like LPD or LUF. LUF, high resistance flow in the luteinized follicles with hyperechoic outer margin, hyperechoic endometrium, but it's thin and has weak flow. LPD, which may be because of CL insufficiency or because of inadequate progesterone receptors, CL insufficiency, thin endometrium, high resistance corpus luteal and endometrial flow, and inadequate progesterone receptors, normal corpus luteal flows, but high resistance flows in the endometrium along with thin endometrium. So to summarize, early recruitment of the follicle, increased FSH, increased endometrial thickness, high estrogen or high progesterone, increased stromal flow, high LH for a short period, increased stromal echogenicity, high LH and N ovulation, more antral follicles, high androgen and high AMH, high uterine artery resistance, high androgen. These are all on the baseline scan. On the pre-trigger scan, good follicular flow, good estrogen production, good endometrial flow, good estrogen receptor development, fluffy outer margins of the endometrium, early exposure to progesterone, increasing echogenicity of the follicular wall, luteinized and ruptured follicle, along with a high resistance. Luteal phase, we have already just discussed normal progesterone level identified by normal corpus luteal RI, normal progesterone receptor development by normal endometrial flow, low resistance endometrial flow, low corpus luteal vascularity, luteal phase defect because of corpus luteal inadequacy, low endometrial vascularity because of inadequacy of the progesterone receptors or inadequate progesterone levels, and luteinized unruptured follicle, hyperechoic walls with high resistance. And remember, in luteinized unruptured follicle, there will be no hemorrhagic echogenicities inside the endometrium. So I've tried to cover a very complex subject, tried to make it as simple as possible, and I'm ready for the questions. So you can please go ahead with that.
Thank you, Dr. Sonal. That was fantastic. A marathon, literally. Really nice. And now there are a few questions. I've tried to group them into categories. The first is about the uterine artery. I'm going to take off my video so that you can concentrate on what you say. The first is, should we report uterine artery PI and RI on both sides? Should we check on both sides and take an average? Or is a single